Good afternoon, everyone. I'm going to tell about my research work entitled Decreased Muscle of Severe Hepatosteatosis, the quintessential body composition predisposing to metabolic dysfunction-associated fatty liver disease. I have nothing to disclose. I acknowledge the support given by ICMR for funding this research work. MAFLD is a growing healthcare concern as this condition has the potential to transform into an inflammatory state that is MASH, cirrhosis, and even SCC. We all know obesity is a known risk factor, but the effect of body composition in terms of adiposity and muscularity remains unclear. The aim of the study was to assess the body composition parameters associated with severe steatosis in patients with MAFLD. This is a cross-sectional prospective study in which we have enrolled diagnosed patients with MAFLD from the outpatient departments of hepatology and clinical nutrition, and we enrolled all patients except lean MAFLD with BMI less than 23, with significant alcohol intake, and with viral etiologies. And the assessment of hepatic steatosis was done with the help of transient elastography or fibroscan, and the hepatic steatosis was graded as severe if control attenuation parameter, that is CAP, was greater than 300, and moderate if it ranged between 237 to 299. The assessment of body composition was done with the help of computer topography. Single slide CT image at L3 level was analyzed using slisometric software, and SMA and visceral adipose tissue was marked at the predefined CT densities. Body composition was characterized by muscle to fat ratio of SMA and VAT. All the statistical analysis was done by SPSS 25. Univariate analysis followed by multivariate binary logistic analysis was done, and cutoff of MFR was derived by ROC. In all, we enrolled 133 patients, out of which the majority had severe steatosis and only 30% had moderate steatosis. Patients with severe steatosis had higher BMI, serum insulin, HbA1c, serum insulin, CRP, and lower MFR, but comparable diet and physical activity as compared to patients with moderate steatosis. On multivariate analysis, MFR was independently associated with severe steatosis, and each unit increase in MFR decreased the risk of severe steatosis by 96.2%. This is a single slide CT image representing the different body composition parameters at comparable BMI. This A shows the figure with a more visceral fat and less muscle mass, and on the other side we have less visceral fat and more muscle mass. And A figure has 0 to the B1. This is the ROC curve for the cutoff of MFR. MFR less than 0.75 with area under the curve of 0.74, and at the given sensitivities and specificity increase the risk of severe steatosis in MAFLD. So hence we conclude lower MFR is an independent predictor of MAFLD, which brings a 4-fold increase in the risk of severe hepatosteatosis in MAFLD, and hence the therapeutic modality should focus on increasing MFR in MAFLD.